Lots of nice people joining us. And it is time to start the drum roll.
Yeah. Hi, everyone. Thank you so much for being here today. It's been so nice to hear a little bit about everyone as we trickle in. That just gets me so excited. So welcome to Health Together, previously known as Maternal and Infant Health Canada's educational webinar series. Today's topic is a continuum from menarche to menopause, understanding cardiovascular risk across the reproductive lifespan, with our esteemed speaker, Dr. Rubee Dev. Thank you so much. Before I introduce our speaker, I like to start a webinar by introducing our group. So, Health Together is a global public health collaborative working to improve the health of women and children around the world while seeking equity-driven solutions to a more sustainable world. We have three pillars, which includes education, research, and innovation. We are made up of doctors, researchers, public health professionals, and traditional medicine practitioners from around the world. If you would like to keep up with everything that is happening in Health Together, you have many ways, all of which I will add to the chat box shortly after this. We have many socials, and we also have a website where you can go to the webinar tab. So I'll put the link in the description soon. And we host 6 webinars per year. So if you'd like to be on our email or WhatsApp list, please send your WhatsApp number and email address to the email address I will again put in the chat. And we will also love your feedback after this webinar because we're always looking for ways to improve. So if you can afterwards, please take a few minutes to fill out a short questionnaire after this webinar, which I will also put in the chat. And as with all of our public webinars, I will add the following disclaimer. This course and handouts may contain general information about medical conditions and treatments, but the information is not advice and should not be treated as such. If you have any questions during the webinar, please write them in the comment box at the bottom of the screen. We will capture the questions and then ask them at the end of the lecture portion. Discussion is one of the key components to our webinar, so please share your thoughts. I'm your moderator, Isabella, and I'm zooming in from the ancestral and unceded lands of the Coast Salish peoples. We also have Dr. Farshaw, the founder and lead of Health Together. And our speaker today is Dr. Rubee Dev, an assistant professor in UBC's School of Nursing and affiliate faculty in the School of Population and Public Health. Dr. Dev's research focuses on global women's health and primary health care. Her program of research sits in the intersection of reproductive and cardiovascular health of postpartum women. Her work entails extensive research to identify the data gaps and opportunities for action in meeting the needs of global women's health and improving care delivery in primary healthcare settings, mainly through collaboration, partnerships, and knowledge translation. Thank you, everyone.
Thanks, Isabella, for the wonderful introduction. Okay, so hi everyone again. Isabella already introduced me, so I'm not going to waste my time on that, but I'm going to talk a bit about how I became interested in this topic. So I spent almost 5 years working as a clinical nurse to take care of pregnant women, postpartum women, and that's how I developed my interest in the area of health of women, I would say. So I started my research career more of as a sexual and reproductive health researcher, and then slightly it also paved towards non-communicable diseases and mainly cardiovascular conditions. So I started thinking about how one's reproductive health also impacts their cardiovascular health. So my current program of research is mainly about looking at the intersection of reproductive and cardiovascular health, mainly for women in their pregnancy and postpartum period. And that's why today's talk is going to be about a continuum from menarche to menopause and understanding cardiovascular risk factors across different lifespan of someone. So before I start my presentation, I would like to acknowledge that UBC Vancouver is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the land it is situated on has always been a place of learning for the Musqueam, who for millennia have passed on their culture, history, and traditions from one generation to the next on this site. And currently, I'm also speaking from my home, which is actually in the land of the Coquitlam people. So these are some of the learning objectives which has already been shared, but I'm going to briefly talk about mainly the reproductive and pregnancy related risk factors. Those are evident to be associated with cardiovascular diseases risk in women. Identify some of the current gaps in screening or the risk assessment tools that we have to identify or predict cardiovascular disease in general population as well as in women. And finally, discuss some of the implications for clinical practice or future research. So I'm just throwing some of the numbers here, and it's just to highlight the importance of how the incidence or prevalence has been increasing. So as we have been hearing and we know, and it's also evident by data. So it's not I am saying, but it's the data which are saying all of these numbers. So cardiovascular diseases are actually the leading cause of death annually, if we say globally all around the world. When we see the annual number, it's 20 million, and almost half of these deaths are among the women. So women account for 9.6 million of deaths annually. This CVD related deaths has jumped globally. So it used to be 12.1 million sometime in 1990, but it has increased to 19.2 million, and the prediction shows it's going to be almost 20 plus or almost 25 million by 2030. In the latest data we have is from 2023, and these numbers are from World Heart Federation, and some of the numbers are from the Global Burden of Disease report from 2025. And these all numbers are compiled from almost 200 countries. So as we can see, the number from 2023 globally, 330 million males lived with CVD, and you can also see the almost equal number of females, which is 320 million females were living with CVD, which is almost 1 in 12 people living with CVD. Each year, almost 53 million people around the world develop CVD. And the good thing about this is 80% of those can be prevented. So that's why there are so many things that we can do as a clinician, as a practitioner, or as a researcher. So these are some of the numbers, and the latest we have is from 2023. So we can see different numbers all across the globe. Almost it's prevalent almost everywhere, and we have been hearing this, and even the number can show that it's increasing in low and middle income countries. So the highest number being in Asia. This is the estimated deaths from CVD in 2023. So the earlier slide showed the prevalence, and this is the number of deaths. Again, people everywhere is dying because of cardiovascular diseases, as we already mentioned, that it's the number one leading cause of death, almost comparable or even in more than cancer-related deaths. So globally, 20 million deaths from CVD occur all around the world. When we talk about the trends in cardiovascular disease, so this is the trend indicated from 1990 to 2024. The ones in red indicates here prevalence among female. The one in blue is the prevalence among males, and the green ones is average prevalence across all ages, both for males and females, so for both sexes. And if we can see the trend, it's rising for almost all ages and for both sex, both female and male. And I have some numbers here. So if we see in terms of number, it's almost the same. So if we see the number of female, which is almost equivalent to the global average or closer to what the prevalence is seen among male. And the trend, as we see, it's increasing for all ages, for both the sexes. I don't know why it's freezing. Okay. So why women's heart health matters? It has become the leading or number one killer of women all across the world, and not only across the world. Even if we talk about Canada, heart disease is the number one killer of women in Canada. So there are multiple risk factors that we talk about, and some of the common risk factors that we talk are about smoking, obesity, diabetes, hypertension, and even though these risks sometimes it's not present in women, they still develop cardiovascular disease. So which means certainly there are, beside traditional risk factors, there are some other risk factors too that women uh, suffer from, or that makes them at higher risk of developing cardiovascular disease sometime in their life. It accumulates over time. So the risks in women, it's not only a one-time thing, but it accumulates over decades, and it's influenced by multiple other factors beside traditional risk factors. And those factors can be reproductive events, adverse pregnancy-related outcomes, and many other pregnancy-related factors, as well as social determinants of health. And this risk accumulation highlights the need that there has to be early detection and long-term follow-up care when it comes to women. And I'm a women's health researcher, so I'm talking about women. Of course, this needs for everyone. Heart disease, which used to be considered as man's disease in the past, but that no longer exists. So it's, of course, men are at a higher risk, but it's also rising among women, and women are at equal risk of developing cardiovascular disease because of multiple additional risk factors. So heart disease is the number one killer of women worldwide and the leading cause of premature death in women in Canada. And the Statistics Canada shows that it's causing 1 in 3 deaths each year among women in Canada. So this is some of the old data, but it also gives us some of the view of the burden of cardiovascular disease in women. So Statistics Canada, and that is from the 2020 report that reported that CVD as the second leading cause of death after cancer in women in Canada. But if we see the current report, actually it is one of the leading causes, leaving behind even the cancer. So if we see the numbers, so 35% of all deaths in women worldwide are caused by cardiovascular disease, and most of them are related to some of their pregnancy or reproductive related risk factors. Okay, so when we talk about risk accumulation across life stages, there are different risks that we talk about. And the number one is, of course, the metabolic risk factors. When we talk about different kinds of traditional risk factors, this also comes under one of them. So long term, when someone is suffering from hypertensive disorder or hypertensive disorders or diabetes-like conditions that affect their metabolic imbalances, and all those long-term metabolic imbalances contribute significantly towards their increasing their cardiovascular risks in different stages of their life. The one that's more unique to women is related to inflammatory and hormonal influences that occurs at the time of pregnancy, and not only at the time of pregnancy, also during the menarche and after menopause. So there are lots of hormonal imbalances or changes that women bodies suffer from, and all those leads to different kind of changes in microvascular system and leading to CVD sometime later in their life. Lifestyle risk factor definitely are one of the important. So this includes diet, exercise, and smoking behavior that also accumulates over time and impact cardiovascular outcomes. Again, this lifestyle can be for both men and women. All these risk factors. Some of them are modifiable, some of them are non-modifiable, and we, as a researcher or a clinician or practitioner, has a lot to do with the modifiable risk factors, but there is also an opportunity in which we can do some about precision medicine to help women for these inflammatory and hormonal changes related CVD risk. So when we talk about different life stages, we talk about adolescence, young adult, during their pregnancy, during their postpartum phase, and premenopause, postmenopause phase. So women are accumulating those risks at different levels, and there is an opportunity to work in all of these different levels. So for example, when we talk about someone having early menarche, so when someone's menstruation cycle starts under 12 years of age, that's evident to be, those women or girls are evident to be at higher risk of developing heart disease later in their lifetime. And all of those are related to increased risk of obesity or insulin resistance that someone develops. Adolescence also is one of the critical period for prevention of obesity. So obesity, we know, is new pandemic all over the world. So that is one thing we are dealing with. And again, that's a critical period. And we all know that obesity is related to different kind of cardiometabolic complications. And those cardiometabolic complications or changes are related to developing CVD. Different phases of reproductive time period. So pre-pregnancy, pregnancy, or post-pregnancy or postpartum period, where there are lots of changes in women's body. So sometimes they develop hypertensive disorder pregnancy. Sometimes they develop diabetes, gestational diabetes, or dyslipidemia. Also, there are multiple autoimmune conditions, which is more unique or makes women at higher risk. So for example, rheumatoid arthritis or lupus, which is more common in women. All of those different conditions and metabolic syndrome that happens during the pregnancy or post-pregnancy period, that increases their risks or long-term cardiovascular outcomes. Postmenopause phase is also important. As we know, there is changes in estrogen and progesterone level in one's body. So again, all those hormonal changes leads to increased CVD risks. Since my area of population is around pregnancy and postpartum, so my remaining slides will be talking. I will be talking more about how those pregnancy and reproductive related risks acts as or subs as an increased risk of CVD in women, but other phases are also equally important. So I'm involved in multiple heart health related conditions. So I do both for both sexes, but one of my current program of research is mainly about optimizing cardiovascular health in postpartum women who have that reproductive and pregnancy related risk factors. Again, I'm not saying that this all the women are at equal risks, but some women are at more risk because of these different risk factors. And these risk factors can be individual risk factors, or they can be occurring, co-occurring. So someone may have that one reproductive and other pregnancy related risk factors. And our current study shows that those who have those co-occurring risk factors had that elevated risks. So even during, sorry, pre-pregnancy, pregnancy, immediate postpartum, early postpartum, or late postpartum, which is my area of research, which I'm exploring more right now. So there are different phases within these. So during pre-pregnancy, we can think about presence of some kind of reproductive risk factors that can be hormone related. Infertility, which our study is now showing is one of the risk factor. Early menarche, which I already mentioned. So if someone is having their menstruation cycle in less than 12 years of age. Other hormonal imbalance conditions like polycystic ovarian syndrome and risks from assisted reproduction, which is in rise all over the world, different kinds of contraceptives, and also autoimmune and reproductive disorders. During pregnancy, some of those reproductive risks could be all those metabolic dysfunction or the adverse pregnancy related outcomes that that a women suffer from, preterm birth, placental abruption, or gestational diabetes. Even for the postpartum, we can look at the risks for immediate postpartum, so short-term postpartum period, which some literature suggests as within 1 to 5 years, and then there are long-term CVD outcome risks, which is from 5 to 10 years. So my current study is mainly about looking at all these different risks, but mainly within 10 years of risks. What are the main CVD outcomes that a women suffer from if they have the history of reproductive and pregnancy-related risk factors? So here I have listed some of the other risks. So within 1 to 5 years, weight retention, persistent hypertension. Some women who develop gestational hypertension, they continue having that hypertension or hyperglycemia that interrupts or accumulates their risks of CVD. And again, we have late postpartum, as I said, between 5 to 10 years. So different kind of CVD risks during that phase, mainly because of remodeling of cardiac and vascular systems. And that leads to their leading to chronic hypertension and type 2 diabetes mellitus, which changes their metabolic profile, leading to increased CVD risk. So why postpartum? Because this is my population of interest for my current program of research. So as we all know that pregnancy is essentially stress test, and many people or many women suffer from adverse pregnancy outcomes during their pregnancy. And that is evident to be linking to their CVD, increasing their CVD risks and associated with having cardiovascular different outcomes, be it heart failure, ischemic heart diseases, and different other heart conditions, which I'm going to talk in a while. And all of those are because of those from stress of metabolic and vascular changes that happens during pregnancy. When we talk about prevalence of adverse pregnancy outcomes, it's suggested that almost 10 to 20% of women in their lifetime suffer from adverse pregnancy related outcomes. And of course, it varies by race and ethnicity. So there are some races in which APOs are higher compared to other race and ethnicity. And all of those CVD risk factors place postpartum women at a higher risk of developing subsequent cardiovascular disease compared to their counterpart who doesn't have any of those adverse pregnancy-related outcomes. And when we talk about adverse pregnancy-related outcomes, I'm mainly talking about the myriad of those maternal and fetal complications that includes hypertensive disorder of pregnancy. So for example, eclampsia, preeclampsia, gestational hypertension, and in rare cases also the HELP, which is hemolysis elevated liver enzymes, low platelet syndrome. It also includes gestational diabetes, placental abruption, spontaneous preterm birth, fetal growth restriction, and small for gestational age infant. So I have been talking about it a lot. So CVD is the leading cause of death in general population, but it's also a leading cause of death during pregnancy and the postpartum period, representing almost 26.5% of pregnancy-related deaths. So when we look at the literature or evidence or all those fact sheets or reports from the past, postpartum hemorrhage used to be the leading cause of death among women in the past. Postpartum hemorrhage is still there, mainly in the context of low and middle income countries, but now CVD is surpassing that postpartum hemorrhage and it has become the leading cause of death even during pregnancy and the postpartum period. So nearly 1 in 5 births is complicated by adverse pregnancy related outcomes. And I already mentioned about those different kind of adverse pregnancy outcomes. So based on the evidence, there is a strong association between adverse pregnancy outcomes and risks for subsequent cardiovascular disease. Literature also suggests that women who experience adverse pregnancy outcomes have almost 2 to 5 times higher lifelong risks of developing CVD. So we can understand the burden of those APOs and CVD in women's life. When I look at the literature and also some of the anecdotal reports talking with the patients, there seems to be awareness and screening gaps. And by awareness, it's not only among the patients, sometimes it's also among the providers, based on the report that I hear from women, mainly postpartum women. So whenever we go for our screening or that 4 to 6 weeks period of follow-up, generally the standard CVD related question that comes up is what's your family history? If there is any CVD in family, do you smoke or is there alcohol consumption? Those kind of questions. The questions that's rarely asked is, have you ever had any pregnancy complications? Which is not incorporated in the common risk prediction tools and which is also not generally asked. Again, I'm not generalizing this, but most of the time these questions are missed in many healthcare setting or in many follow-up visits. And these kind of disparities in awareness and screening lead to delayed diagnosis and poorer outcomes for women. And that's why you would be seeing that CVD in women is underdiagnosed or undertreated. So those are one of the reasons that we are left out during the screening. So we actually don't get screened for reproductive and pregnancy related outcomes that's actually related to CVD later in life. So about postpartum cardiovascular follow-up, it's important. And most of the time, I would say it's an important opportunity for screening risk factor, mainly those reproductive and pregnancy-related risk factors that has long-term cardiovascular outcome association. So during the screening, postpartum screening actually helps identify those cardiovascular risks that can help to diagnose early, screen early, diagnose early, and then provide that tailored intervention to women, which can actually help them improve their long-term health outcomes. Risk factor modification. So addressing those modifiable risk factors, as I had mentioned, that can help postpartum women reduce their future cardiovascular disease risk. And all these cardiovascular follow-up, if this can be built in a standard healthcare system, can help long-term surveillance. So continuous cardiovascular monitoring, supporting postpartum women to prevent from developing future CVD and providing that timely intervention. So when we talk about current postpartum follow-up, I'm not saying there is not, it's there, but it's often concentrated around that traditional 4 to 6 week postpartum visit, which even I had experienced during my postpartum period. But after that 6 visit, there is no one who would ask you about any of the cardiovascular related risks. So there is that gap in surveillance during the extended postpartum period. So we are not talking about that extended postpartum period where there is a more risk of developing CVD. And also, though important, most of the maternal health concerns during that postpartum follow-up receives less attention, and it's mainly because of that infant-focused care. So if they are feeding well, if they are gaining weight, that's important, very important. But at the same time, health of women is important too. So which is missing in the current standard of care. So it's important to integrate that reproductive and pregnancy-related history into cardiovascular assessment. This can, again, within these assessments, so there has to be pregnancy history inclusion in which we talk about or assess for any adverse pregnancy-related outcomes. So all those gestational diabetes or hypertensive disorder of pregnancy. Any reproductive disorders impact, so reproductive disorders, and by reproductive, I mainly I'm categorizing a pregnancy as all those adverse pregnancy related outcomes, and reproductive mainly as anyone having early menarche or anyone having PCOS. So those kind of disorders that can affect cardiovascular health, and those should also be considered during assessment. Menopause is important, though it's not part of my current program of research, but menopause is super important because all those changes related to different hormones increase the risk of CVD in women. So menopause status is also a significant factor which can be assessed, and that's mainly for the extended postpartum period. So that doesn't fall in the immediate postpartum period. And that's why there is a need of long-term surveillance, so that not only includes that 4 to 6 weeks period, but also those early period and then late period of postpartum. And other related risk factors which can be emerging. So every new literature suggests of new emerging risk factors. Researchers have explored many, but there are also many that needs to be explored. So there are ongoing research looking at different kinds of risk factors that's unique to women and that can be considered in the risk assessment in the future. So there are multiple cardiovascular disease risk prediction tools, and if you had heard of it, the most commonly used is Framingham Risk Score, which is also used in the Canadian-based system. And there are other different risk assessment tools. So, for example, Cardiovascular, which is mainly for cardiac disease in pregnancy. There is modified WHO classification tool. There is Registry of Pregnancy and Cardiac Disease, QRIX, third version, and the most recent one is the California Cardiovascular Screening Tool. All of these risk prediction tool calculates a person's risk of developing CVD. But one of the gap here is none of these existing tools take into account the reproductive or pregnancy related risk factors of CVD. I think most recently, Heart and Stroke Foundation came up with some kind of questionnaire that do actually talk about these reproductive and pregnancy-related risk factors, but I'm not yet sure if it's incorporated into any EMR system or how it's used. But there has been development that includes. So when you talk about future directions, based on all these, what I have identified until now, there is a need to develop and validate female-specific risk prediction models that can combine. So I'm not saying traditional risks are not important. Traditional risks needs to be incorporated. But along with that, if we are looking at exploring cardiovascular disease risks in women, there has to be reproductive and their pregnancy-related risk factors that's included in the risk prediction tool. So one of my research is about prediction research, in which I started with findings. So that this is the process. That's a standard process, and I'm following it. So starting with predictor finding study. So my research team conducted a systematic review to explore all of those reproductive and pregnancy-related cardiovascular risk factors that are evident to be associated with increased risk of CVD in postpartum women. So it's in the manuscript development phase, and I'll share some of the results, but it's still yet to be published. Our team also conducted a scoping review to link those, to identify what are those mechanistic links that actually increases the CVD risks in women. And again, that study is it's under review. So the next stage is prediction model study. We recently got access to BC Perinatal Data Registry, which we are planning to use as a main database to develop the CVD risk prediction tool. So we are going to use, and our current team is also working on that. So trying to develop a cohort of postpartum women with CVD. And we are also linking the BC Perinatal Data Registry with other kind of databases to capture as many variables as we can. So for example, with the NACERS database, also the DAD database. So we are linking the BC perinatal data registry with different databases to capture as many variables as we could to develop a CVD risk prediction tool that can incorporate that pregnancy and reproductive related risk factors. So this is an ongoing phase that we are currently working on. And once it's developed, there are multiple phases. So once we have developed the risk prediction, I would say algorithm, that's what we are currently working on. Once that algorithm is developed, we will have to translate it into a usable version of tool that can actually be used by clinicians or providers to assess the risks among the women. So once it's developed, the next phase of the study will be about prediction model impact study. So just because we have developed tool doesn't mean it's going to be useful, or it can be used appropriately or implemented in the healthcare setting. So our team is going to evaluate the effect of using that model or tool and to see how it guides postpartum women care compared to a model that is not using any such tool for women. So this is just a brief of different risk factors that was found in our systematic review. We differentiated it into traditional risk factors, reproductive related risk factors, and pregnancy related risk factors. And all of these were responsible for different kind of risks in a postpartum women. So be it angina, myocardial infarction, inoca, or spontaneous coronary artery dissection, and different kind of, and also most commonly the peripartum cardiomyopathy. The most commonly found risks among the adverse pregnancy-related outcome that our study found was mainly the preeclampsia as an individual risk factors, but then there were also co-occurring risk factors that elevated the risks in women, and those co-occurring risk factors were, for example, when that preeclampsia was co-occurring with gestational diabetes. So those women had increased risks of CVD compared to women who only had preeclampsia. Among the reproductive related risk factors, interestingly, infertility was found to be the main predictor of CVD in women, and we are still exploring justification of that. And of course, there were some limitations in our study. We couldn't include all different studies that could have shown that risk, but yes, infertility was one of the main, and all of these are based on the 86 studies that we have included in our review. And since this review was conducted in a year last year, so we are trying to see if we missed any recent articles. So we are currently in that phase to explore if there are any new evidence of new risks in that has been associated with postpartum CVD. So when it comes to future directions in women's cardiovascular health, we talk about those emerging sex-specific risk factors that's unique to women. So many researchers all around the world, they are continually doing this research to identify those emerging cardiovascular risk factors that are unique to women and that can help improve diagnosis and treatment. So we can do a lot with the prevention strategies. So there is a need that we develop targeted prevention methods, and one of them being developing the tool. But then there can be other different targeted prevention methods that we can do to reduce that cardiovascular disease incidence in women. And finally, personalized care approaches. So advancing that precision medicine and personalized care to tailor cardiovascular treatments to individual women's needs. So all those tailored interventions or risk-based tailored recommendations that can help improve CVD outcomes in women is important. And these are some of the future directions for women, improving women's cardiovascular health. So key takeaways I would say from my today talk is mainly that cardiovascular risk changes throughout female reproductive stages from menarche to menopause, and there are different kinds of risks that accumulates over time, and all those different stages of female life is important in terms of when we talk about which milestone we can target and which reproductive milestone we can work to offer that crucial improvement strategy that can help identify early cardiovascular risks in women, and then we can develop those tailored intervention that can help improve cardiovascular outcome in women. And of course, lifelong cardiovascular health, it's not a one-time thing. So all those risks needs to be assessed time to time, like other risks assessment that we do, because we all always know that prevention is better than cure. So early identification will help us identify risks on time, and then we can develop those tailored intervention to help women prevent them from developing that cardiovascular disease in their life, and thus improving their quality of life across their whole life continuum. So that's all about my talk today, and I would open this for discussion. And just to acknowledge that I do not consider myself as an expert in this topic, but I'm someone who is interested in this topic. So I would continue my program of research in this area. So thank you.
Thank you so much, Dr. Dev. That was amazing. Yeah. Isabella, do you want to moderate? I know that we have one question from Alina.
Yeah, Alina, go ahead.
Is that in chat?
Yeah, she wrote it in the chat. I was wondering if you wanted to read it aloud yourself, Alina. Oh, she's still here? I remember she said she had to go. Okay. Maybe you could read it aloud, Isabella, or I could just ask a question while we're doing that. So yeah, so Dr. Dev, thank you so much. I understand at the end you said you're not an expert in this area, but I feel like the findings that you showed, like for me, who's a women's health researcher, I don't think I had quite realized that this is the #1 cause of death for women worldwide, and that it's the leading cause of death for women in Canada. And that, and we always have been talking about postpartum hemorrhage as the leading cause of death, and we've known that CVD has come to the top of that again globally. So it is an area that's been so ignored in women. And I'm wondering if you can talk a little bit more about the kinds of things that you as a clinician would tell your patients to do to prevent CVD risk. What are we seeing as the main factors that cause CVD? And then a secondary question is, a lot of times we hear about women actually having a heart attack and going into emerge and being told to just go home. So if you can talk about what are the signs and symptoms so that those of us here, if we see a woman having this kind of distress, that we can know how to identify it.
Yeah, thank you, Farah. That's important. So, as a clinician, if you say what I'm going to say to my patients, well, I'm not a clinician right now, but I can definitely talk a bit about it. And if there is any clinician in the group, feel free to chime in or add your wealth of knowledge. So we talked about different kind of risk factors. We said they are modifiable and there are non-modifiable. So once we know that someone is at risk, we can definitely talk about those modifiable risk factors first, which they can actually work on and prevent their future CVD risks. But there are also some non-modifiable, like we can't do anything about it. I mean, not much. um, so for those risk factors, I would say at least we have to be aware of it so that it's detected early, it's screened early. So as I said, when we talk about those different adverse pregnancy related outcomes, so one has to be aware of it. So if I develop preeclampsia or eclampsia during my pregnancy, I should think of that maybe I'm at increased risk of CVD. So when I'm meeting my healthcare provider, I'll have to talk about it, ask them if there is anything that I can do about it. Maybe simple things, monitor our blood pressure, in a regular basis so that we know that it's under control, and if it's not, what we can do in the future. So being aware of it, talking to our healthcare provider about our risk, and following the recommendations that our provider suggests. And of course, you also talked about different kind of sign and symptoms, and that's a different topic again. So women experience different kinds of sign and symptoms compared to men. So the most common thing that we see all of in the advertisement, that they show having pain in the chest, which is again can be common in men, but women doesn't actually, they may experience that, but not always. So sometimes it's mainly nausea, headache, or different other symptoms that they experience, which can indicate that there is some CVD risk, and it's not always about chest pain.
Yeah, we've heard about women who've died of heart disease without any practitioners actually recognizing the signs and symptoms. Yeah. Are there any other questions, other people? I have so many. Okay, I will indulge if that's okay, Isabella.
Yes.
Dr. Dev, you also talked about different ethnicities having a greater risk. And as a South Asian person, I feel like I'm in the category of the greater risk. In fact, I've been told by clinicians, like we have this healthy heart clinic at St. Paul's Hospital, and apparently almost everybody in that clinic is brown like me. So I'd love to hear if you have any thoughts on what South Asian people can do to address heart risk factors, and well, do you think diet or sedentary lifestyles or stress or poverty, what are some of the more public health issues related to this?
So it's a good point. So it's a combination of all. So I would not say there is one specific risk factor. It's always a combination. And one of the things that I talked about was that accumulation of risks. So it's not one thing. It gets accumulated over time. And you are right that South Asian population at higher risks. Some of the study links it to their diet. Most of the study links it to the visceral obesity, which like even if we look lean and thin, that visceral obesity around our, or central obesity we call it, around our abdomen, that's linked with higher CVD risks in South Asian population as a whole. So and there is genetic component to it as well. So we cannot change genetic component, but whatever things we can do by modifying our behavioral lifestyle, that's going to help improve CVD outcomes in South Asians. But there is more research needed that looks at that genetic component, like why only those visceral changes make them at higher risks.
Yeah, that visceral fat, that's a big one, isn't it? Yeah, the skinny fats, the people who don't look like they've got it and they've still got it. Yeah. Jeff has a question.
Is there certain diets that would help reduce CVD? Like I heard oatmeal is a good one.
You said oatmeal?
Yeah, oatmeal they said is a good one for your heart.
So again, I would only talk about the evidence, and evidence suggests that Mediterranean diet, those are the main that suggestive of improving CVD outcomes. That's what the evidence says again. Yeah, I mean, of course, oatmeal is good too.
Thank you.
Other questions? Isabella, do you want to read out Alina's question?
I can read it.
Okay.
So Elena says, we often hear so much about lifestyle choices, so it is very refreshing that you highlight the inflammatory and hormonal influences. Has your research explored the perceptions from women of the postpartum follow-up they receive and how it creates any awareness of increased risk of CVD? So, I mean, that's a good question, and that's what I highlighted in one of my slides, in which I said there is a lack in awareness and screening, and we don't talk about those hormonal changes or the inflammatory changes that women body goes through after that pregnancy and after experiencing those adverse pregnancy outcomes or any other, let's say, postmenopause stage. So those are the things that, and again, I said I don't want to be generalizing everything. Of course, there are some providers who do ask about that and work towards it, but then in most of the cases it's lacking. We don't talk about those changes, inflammatory or hormonal changes, and we don't talk much about how we can address that so that it reduces CVD risks in women.
Okay, yeah, thank you. So I just wanted to ask any of our international people who are here, Dr. Andy Ugo or Joseph Adoyo, anybody who wants to say anything about the situation in your own country about heart disease in women? Please go ahead and unmute. I know sometimes the internet connection isn't so good where you are, but please go ahead and unmute if you would like to say something.
Hello, Sof.
Hi, Joseph.
Yes,
Hi, Joseph. Hi, Joseph. Please go ahead.
thank you so much. My name is Joseph Adoyo from Kenya. Now, I'm really excited by this topic, and I think it's a current situation that is affecting and is also on top of the list in public health challenges so far. In your presentation, you talked about and it is all known that screening and awareness is one of the greatest challenge. I don't know. I was wondering if are there some best practices that you can talk about improving the screening for this before we get to cardiovascular diseases. Actually, we do review our maternal perinatal death reports and surveillance in our country and in our county here where I am. And most of the causes that we list are preeclampsia and eclampsia. And some of these things, they start even before, during the pregnancy. In as much as, according to yours, you see, you are majorly looking at postpartum period.
Mm-hmm.
So are there some best practices that you can talk about in improving screening? Otherwise, thank you for that good presentation.
Yeah, thank you very much, Joseph. So that's what I mentioned. We are still struggling, or there is still lack of that standard screening. So when we, and it's not only the context of Kenya or any other countries, but I think it's all across. We do talk about it's more of an infant-centered care when we meet postpartum women, and and there are some mental health researchers, so you can think about it. We don't talk about their mental health. We don't talk about their cardiovascular health. We generally talk about if the wound is healing, if they are doing okay, if there is any pain or not. So those are some of the common questions that we ask to postpartum women when we meet in that traditional 4 to 6 weeks period. That follow-up, which is offered, I think, across all around the world. So the basic screening and the standard of care that I as a researcher envision is providers asking them about those risks. And again, I'm not sure if this can be implemented, but I'm thinking of if all those different pregnancy and cardiovascular reproductive related risks can be incorporated within that electronic medical record, because it's hard even to remember all those things about different patients. So if women has those different risk factors, and that electronic medical record in future can flag someone has these multiple risks, so maybe this woman is at higher risks, and you should follow up with these women. So that's what I'm envisioning by developing a tool that can be incorporated within electronic medical record, and that can help providers flag those women who are at higher risks. So that can be one, but again, we all are in a continuous phase of exploring different preventive strategies, improving screening methodologies. So there is more to do, and there can be different standards of care, but the ultimate focus is that we have to ask about those different risk factors to women who, as a provider who is providing care to our patient, we will know that they have these different risks. We are just not incorporating that in our risk profile.
Dr. Dev, I really see midwives being at the forefront of this around the world. I really see this
Yes.
being something, an innovation that midwifery could do that would start to impact the rest of the healthcare system. And I hope that that happens in Canada first, because midwives are really the only professional who have 4 years of training in pregnancy, and they really are the experts. So once they start seeing a majority of pregnant people in Canada, I can see that being a really good clinical innovation that midwives actually bring about. Before we conclude, everybody, you'll see that I have been putting in this feedback form, and we'd really appreciate it if you could click on that, please, and fill it in, because we like to learn from you about what has worked and maybe what you would like us to improve for our webinars. We only do 6 a year, so please do click on that and fill it in for us. That would be great. Are there any other questions for Dr. Dev? I'm not sure if Dr. Ugo is available now from Nigeria. Maybe not. Okay. All right. Well, I just want to say from the spending the last hour with you, Dr. Dev. Oh, sorry, Dr. Ugo, please go ahead.
Hello, good evening. Sorry, my name is Andrew Gochku from Nigeria. I'm referring to this topic. I'm sorry for late joining. This topic emphasizes on a lot of stuff, and is a very good one. Kudos to the presenter. My own emphasis on the Nigeria aspect is accessibility, especially in the rural area. Most of these kind of cases tend to be an issue because of the accessibility available to them. So, and again, they find it difficult to access the fewer stuff given to them. So my own simpler question is, how ways can we do in reaching out to the rural area in terms of these cases? Thank you.
Oh, that's an important piece of question for a global health perspective. So we always keep talking, and thank you, Dr. Ugo. So we are dealing with that equity issue, and I would say again, it's the issue all around the world. Even in a developed world, we have that resource limited setting where we can't reach on time, or where participants from where or patients from where we cannot get that equal opportunity to get that higher level of service. So I would say it's not always possible for us to reach there or them to be here. So there, and lots of AI things are coming, and lots of digital health, telehealth that's coming, and we are utilizing that. And we utilized that during the COVID-19 period. So we do have some experience now of improving health of people overall using those technologies. So that can be one. And again, there are also I would acknowledge that there are settings where we can't even reach using digital health, telehealth, because of different other constraints. And there is a challenge of reducing those number of visits. So I don't exactly know how we can do for that. I mean, currently I don't have anything in mind, but if there is any amazing idea from this wonderful group, as I always say, please feel free to share your suggestion. But those digital health, telehealth things are something that comes to my mind when I think about reaching to the resource constrained setting people. Of course, if government thinks to, it's more in the hand of policymakers, like how we can increase that access to those resource constraint settings. Yeah, I mean,
Yeah, I've recently been working in Nigeria in a rural and peri-urban area, asking people about health services. So I've definitely seen what you're talking about, Dr. Ugo, in terms of the lack of services and the lack of accessibility. And I feel like from a public health perspective, doing more education in prevention and health promotion, using methods that are accessible and available through, like, I think one of Nigeria's greatest public health tools that is completely untapped is Nollywood, the amazing film industry that exists, and the music industry. Nigerian music and film is a fantastic way of getting out messages. There was that brilliant film about Ebola in Nigeria. I think it's called 90 Days. I know the filmmaker, Steve. So I personally would think using non-medical techniques would be a really good way in Nigeria, because those are industries that thrive in Nigeria.
That's excellent. Thank you, Farah. And maybe that concept
Yeah,
in
that's a
debate.
good one.
Dr. Dev, we have come to the conclusion of this wonderful webinar. You have given us so much food for thought, our own organization to think about how we can take up some of these issues. And Isabella, who is the head of our social media team, I call her boss girl. She is very good at what she does. So I can see us doing more in this area, and it's really clearly an ignored global disease that we need to be taking up. But I'd like to thank you very, very much, and thank all of you who joined us today. And thank you, Isabella, and thank you, Ted Beer, for doing all the work. And thank you, Patty and Healthy Seminars, for putting this on. It takes a little village to put these webinars on. So thank you to all of you. And thank you again, Dr. Dev. Wonderful.
Thank you, Farah, and thank you all the attendees who attended this webinar from all around the world. And thank you for listening me and this important topic.
Yeah. Bye, everybody.
Bye. Thank you. Take care.
Bye. Bye, Jeff. Bye, Susan. Bye, Rashidatu. Bye, Dr. Ugo.
Bye
Bye.
bye.
Hello,
Bye.
Chiran. Hello. Bye. Bye. Bye, Sahaj. Bye, Joseph. Chiranjeevi. Great to have everybody here.